Hi students, so the conclusion of mucosal block theory is homeostasis of ion metabolism is maintained by regulating ion absorption only, not excretion. That is called mucosal block theory, right? Regulation of ion absorption not by its excretion. This is the concept of mucosal block theory. So when ion stores are less means its absorption is increased. If the ion stores are adequate means the absorption level will be decreased. Mucosal cells only will decide either the uptake or utilization or reutilization or storage form of ion. Intestinal mucosal cells. So these 4 or 5 lines with the one diagram for your mucosal block theory question answer. 5 mark short notes. Okay. Next we have 3 subtitles for this ion metabolism: transport, storage and excretion. Excretion already I told you, not excreted by kidney, that is in urine. So no urinary excretion, that is why it is called as one-way element. Some minimum minor amount or minimum amount of iron is metabolized through bile, feces and menstrual blood, right? This is regarding excretion. Coming to the storage and transport. First one is storage. The form of storage storage form of iron is ferritin. So it is stored in liver, spleen, bone marrow and intestinal mucosal cells. Chemosiderosis is another storage form of iron which is present in also liver. This storage form of ferritin is increased in acute inflammatory reactions, viral infections, bacterial infections and COVID-19 like infections also. Decreased in iron deficiency anemia. These are all the 4 points for your storage of iron. That is storage from ferritin, where it gets stored, how it is increased and how it is decreased. Next one is transport form of iron is transferrin. The name itself transferrin. Synthesized from liver. We have one condition, iron deficiency anemia, where the transferrin as well as TIBC, that is total iron binding capacity, both will be elevated. This is one of important MCQ question, and also sometimes they will be asking in some clinical scenario means they will be giving these parameters TIBC, total iron binding capacity. It is nothing but combination of transferrin plus iron, right? So transferrin synthesis from liver increased in iron deficiency anemia. In iron deficiency anemia, TIBC also increased. TIBC means total iron binding capacity. So these are all the related subtitles of excretion, storage and transport. Next one is disorders involved in iron metabolism. We have 2 disorders. One is deficiency leads to iron deficiency anemia, and excess amount of iron will produces toxicity of iron metabolism. Iron deficiency manifestation, normal level, clinical features and causes, why it happened, how it occurs like that. So we all know the normal hemoglobin level is 14 to 18 gram per day, but less than 12 means iron deficiency anemia. Okay. So hookworm infestation, that is the most common infection in India, worm infestation. Second one is repeated pregnancies. Next, nutritional deficiencies. And the last one is chronic blood loss conditions. These are all the causes produces iron deficiency anemia. So for that patient, what are all the clinical manifestations? Affects brain, affects GIT like that. So the anemia type is MCHC, that is microcytic hypochromic anemia. Very, very important MCQ, microcytic hypochromic anemia. Then mental apathy, sluggishness activity, lowered memory. And then loss of appetite, growth retardation is also there. Then achlorhydria, dysphagia and spoon-shaped nails, chylonychia. These are all the clinical manifestations suggestive of iron deficiency anemia. Second, for this iron deficiency anemia, how will you manage or what is the treatment? Like that means folic acid, first one is, second one is iron third one is vitamin C and E. That is 3 vitamins and 1 mineral. So 1 mineral is iron, that is 100 milligram per day, whereas folic acid is 500 microgram per day. Vitamin C and E, these two acts as antioxidants. That is, it's scavenging the free radicals. That is why iron deficiency anemia treatment is folic acid, iron, vitamin C and vitamin E. Okay. Next, coming to the toxicity disorders, we are having two disorders. One is hemochromatosis, another one is hemosiderosis. Both are accumulation of excess iron will get deposited. So, excess accumulation of iron produces hemosiderosis. Routine cause for this hemosiderosis is, for example, repeated blood transfusion for hemophilia and hemolytic anemia patients will go for hemosiderosis. Very, very important MCQ. Repeated blood transfusion patients like hemophilia and hemolytic anemia, they will go for hemosiderosis. Whereas hemochromatosis means again accumulation of the excess iron will be in the liver, spleen, pancreas and skin. Liver, spleen, pancreas and skin. So we have one conditions coming under this hemochromatosis called bronze diabetes. That is involvement of three organs. That is triad of bronze diabetes is, one is pancreas produces diabetes mellitus, liver produces cirrhosis and skin produces skin pigmentation. These three are coming under bronze diabetes. So if any exam or any MCQ anywhere in the MCQ bronze diabetes means, first you have to think of iron toxicity. Iron toxicity not only produce liver problem, kidney problem, pancreas problem, skin problem, like that. You have to pick up the answer. You have diabetes mellitus, cirrhosis, diabetes mellitus, cirrhosis and skin pigmentation are the cardinal features of bronze diabetes. So like calcium, iron is also very, very important. Essay question, clinical scenario question, short answer question and also MCQ question. You have to read A to Z thoroughly about iron metabolism.